Hello and welcome. My name is Emily Kosick and I'm the Knowledge Manager at the Canadian Institute for Public Safety Research and Treatment. It's my pleasure to be hosting this event made possible by a partnership with the Canadian Institutes of Health Research. Today, we will continue our series on research done for the Post-Traumatic Stress Injuries and Public Safety Personnel Catalyst Grants. There are a few housekeeping notes before we begin the presentations. All attendees are in listen-only mode. This is to control feedback during the presentation. Today's session is being recorded, so you will be sent a copy within 24 to 48 hours after the presentation. If you do want to ask questions, we encourage you to use the questions box and I will ask them at the end of the session. So after all three projects have been presented, we will go ahead with questions from the audience. Some organizations do block GoToWebinar software, so you may have to join by phone if you're having a problem hearing or seeing the presentation today. I have also attached handouts for this session. In your control panel, you'll find 3 handouts. These include the agenda for today and English and French versions of the presenter's knowledge translation reports. These handouts will be posted on tomorrow on CIPSRT's website, along with a recording of today's session. So if for some reason you can't access them today, they will be available on the website tomorrow. So now I'd like to introduce our first project for today. And the project is titled Evaluating Critical Incident Management and Peer Support Programs for Public Safety Personnel. I am going to invite Dr. Jill Price, who's a postdoctoral fellow at CIPSRT, and the knowledge user, Jeff Sych, to join us on the screen. And I will turn over presenting control to you, Jill, so that you can display your slides. So thank you so much both for being here today, and I look forward to your presentation.
Thank you.
Thanks, Emily. Okay. So today we'll be discussing our CIHR project with our revised title, Mental Health Support Services for Canadian Public Safety Personnel. My name is Dr. Jill Price. I'm a postdoctoral fellow at CIPSRT, which is located at the University of Regina. I have no relationships with commercial interests, and my only research support is through CIHR.
And my name is Jeff Sych. I'm a registered psychologist in the province of Alberta, as well as the clinical director of the Alberta Critical Incident Provincial Network.
The CIHR project research team includes Dr. Nick Carleton, Dr. Amber Fletcher, Dr. Rose Riccardelli, and Dr. Greg Anderson. As the project grew, our team has expanded, so we would also like to express gratitude to all others who have contributed to this project.
So as a function of their occupations, public safety personnel are frequently exposed to a wide variety of potentially psychologically traumatic events. To help address the impact of potentially psychologically traumatic events, there's a growing number of mental health support services that are intended for public safety personnel. However, many of these services contain comparable material and deliver high levels of reliability across agencies and provinces with little or no empirical evidence.
To address these concerns, the study was designed to conduct an environmental scan of the various support services intended to maintain or promote mental health among Canadian public safety personnel, to highlight areas of overlap and divergence to increase mental health literacy, and identify elements of highest importance to users and experts to improve public safety personnel mental well-being. The environmental scan began with those highlighted within the blue paper, conducted by Bashai and Carleton in 2016. In total, they highlighted 14 support services, of which many pertained to critical incident stress management, also known as CISM, which is why the name of this project was previously centered around it. 4 years later, in late 2020, a new article by Anderson and colleagues completed a similar review and found similar results. However, since September 2019, we have identified 74 different organizations that offer over 200 mental health support services intended for public safety personnel, a list that is being continuously updated. We are currently in the process of developing an online repository for this information, which we anticipate will be ready for use in early 2021. We want to be clear that in providing this list, we are not endorsing these support services as they have little to no empirical evidence. When ready, the website will include filters, allowing public safety personnel to identify mental health support services most appropriate for them. Let's take a look at some of the filters that will be available. The first filter is type of service. Although there are more than just those listed here, these are the top types of service. Most identified is resiliency-based services, followed by peer support and psychotherapy. There are also services for mindfulness, addiction, crisis intervention, mental health retreat, suicide prevention, animal-based, such as canine and equine therapy, and chaplain services. The second filter is modality. So how are these services being delivered? The top modality is in person, but there are many other options available. For example, as a result of the pandemic, many services have developed online alternatives, such as synchronous and asynchronous. Synchronous means live delivered support, whereas asynchronous refers to pre-recorded. We want to highlight that most have indicated that these online services will continue even post-pandemic, providing new alternatives for rural and remote public safety personnel. We are also hoping to add location services. So if you're looking for an in-person service, you'll be able to filter, showing you where these in-person services are located, so in which provinces and territories, and hopefully filter to see which services these are that are available in these locations. The third filter will be language. As expected, most services are available in English, but we are pleased to hear that more and more services are available or are being developed in French, and that there are even a few offered in Spanish and one in German. The fourth filter is privacy, something that is very important to the public safety personnel community. There are two types of privacy that we are highlighting: anonymity and confidentiality. Anonymity is when the identity of an individual is kept private, while confidentiality is when information shared by the individual is kept private. Another filter is number of participants. So is this service delivered as a self-help tool, or is it being delivered one-on-one or in groups? Self-help tools consist predominantly of apps and online asynchronous support services. One-on-one services consist predominantly of psychotherapy, as well as some peer support, and group services consist predominantly of peer support and resiliency-based services. Another feature that we will include and wanted to address today is the cost of these services. Most services are being offered to public safety personnel for free, while 82 services have a cost associated with it. Costs range from $10 to $75,000 per service. Keep in mind that the term service covers everything from a meditation CD to a 60-day inpatient mental health retreat. Cost of service can be borne by the individual, employer, or third-party insurance.
The second phase of the project is to highlight areas of overlap and divergence to increase mental health literacy. Given the wide variety of services identified, much greater than ever expected or anticipated, we decided to focus on three of the most intertwined or commonly occurring services. So crisis intervention, peer support, and resiliency. Instead of evaluating each organization's material, we decided to evaluate the instructor's training courses, sometimes referred as train the trainer courses. This decision was made since we have no way to evaluate fidelity at the delivery at the time. So to do so, we developed an online survey using Qualtrics. In total, we reached out to 29 organizations, of which 22 successfully completed the survey. For the purpose of this presentation, we're going to discuss 5 main areas of overlap and divergence of these training courses. The first feature is type of training course. In other words, once trained, how will facilitators deliver the mental health support services? Specifically, will it be delivered in one-to-one or in groups? For those that offer group services, is it delivered in an informational and/or interactive format? The second feature is instructors. Who can deliver their support services? And the third feature is SOP, Standard Operating Procedures. Specifically, we focused on 4 components. First, cost. Is there a fee to take the training course? And who's responsible for covering the cost associated with the training course? The individual, the employer, or a government agency? Psychological triage. How does each training course identify who needs support? Delivery of support. Do the organizations have SOPs during and/or after a request for support? And fidelity. Fidelity is the extent to which delivery of a support service adheres to the model originally developed. Do the organizations implement fidelity checks for its facilitators? And if yes, how and when? The fourth feature is gender. Specifically, do these training courses acknowledge and teach about gender differences in experience of stress, coping strategies, disclosure of mental health symptoms, and gender dynamics between peers and peer supporters? The fifth feature is empirical evidence. Have the training courses and delivery of the mental health support services been empirically evaluated for their effectiveness?
Based on the findings from phase 2, it became very clear that there is little consensus about the training and delivery of these services, which brings us to the last and current phase of this project, to identify elements of highest importance to users and experts to improve public safety personnel mental well-being. Although all these services warrant further investigation, we decided to begin with peer support, as it is the most sought after by public safety personnel. For this phase, we obtained training manuals from 14 organizations and counting. Using the elements from phase 2, we are coding the training manuals using NVivo for both quantitative and qualitative analyses. The quantitative analyses focus on how are the elements mentioned in the training manuals, and if so, how many times is each element mentioned? While the qualitative analyses will focus on an evaluation of how each element is mentioned. The purpose of these analyses is to understand how prominent each element is for each organization and whether any elements have been missed. Following these analyses, we will be conducting a modified Delphi method. A modified Delphi method is a process used to arrive at a group opinion or decision by surveying panels of experts. For this project, we have decided to use 4 panels of experts. The first panel will be just of public safety personnel. The second will be public safety personnel leadership. This refers to anyone giving orders to members of their organization or making policy decisions. The third, public safety personnel researchers. And the fourth, public safety personnel service providers. The modified Delphi method will consist of 2 rounds. In the first round, we will present a list of possible peer support elements provided from phase 2 to the expert panels. The expert panels will then be instructed to identify which elements are most important for peer support and which are not. Following, we will calculate the average for each element per expert panel. In round 2, we will present the same list of possible peer support elements back to the expert panels, but this time we will include the element averages for each panel. The panel experts will then be instructed to review their previous answers with the element averages. If there's a significant difference in importance attributed to an element between expert panels, we will inquire for some qualitative feedback. For example, what is your interpretation of this difference? The second round will hopefully allow us to then create a list of the most important peer support elements as identified by various experts. But we want to stress that the point of the modified Delphi method is not forced consensus, rather a better understanding of which elements each panel deems most important and why.
So to conclude, there are many mental health support services intended for Canadian public safety personnel. That a website for support services and current empirical evidence will be made available in early 2021, a link for which will be made available on the CIPSRT website. Again, in providing the list, we are not endorsing these services. Overall, there is little consensus about the training, delivery, and effectiveness of these services, and as a result, a list of support elements of highest importance to users and experts is needed to improve mental health literacy, support practice, and hopefully support continuous improvements to guidelines for care, which will support research efforts that may ultimately lead to national standards. Thank you, and we are happy to answer any questions at the end of today's presentation during the designated time.
All right, thank you both so much for your presentation. Really interesting work, especially with such a large breadth of information you're having to cover. I am going to go ahead now and welcome our second project team to the presentation. The second project today is called Identifying the Impact of Formal and Informal Critical Incident Interventions on Firefighters' Exposure to Post-Traumatic Stress Injury in a Northwestern Ontario Fire Service. Our presenter for the day is Dr. Kathryn Sinden. She's an assistant professor in the School of Kinesiology at Lakehead University, and her knowledge user is Regan Bolduc. And Dr. Sinden, I will go ahead and give you control. So we just need, yeah, perfect.
Oh, sorry. What is screen this? Is that okay?
No, it looks like it's got a duplicate. There we go. Now you're good.
Okay.
Yep, you're good.
Too many. Is that okay?
Yes, we can see it very clearly.
Okay. Great. Okay, well, thank you everybody for joining us this afternoon. The title of our talk is Identifying the Impact of Formal and Informal Critical Incidents on Firefighters' Exposure to Post-Traumatic Stress Injury in a Northwestern Ontario Service. This is a CIHR funded grant, and I'm looking forward to presenting the results of this work with knowledge user first class firefighter Regan Bolduc, who is also the co-chair of the Critical Incident Response Team at within Thunder Bay Fire Rescue. So this work builds on some pilot work that we conducted on the year prior to us submitting for this grant. And obviously, as we sort of conducted that pilot work, we were looking at a lot of different factors that sort of inform and impact firefighter work health. And sort of set this grant within that context. So we know that firefighters experience high rates of injuries, physical injuries, musculoskeletal injuries, but they also are obviously experience high exposure to factors that predispose them to post-traumatic stress injury risk. And one of those factors is critical incident exposure. So we were sort of reflecting on that from some of our pilot work, and tried to see whether or not this particular project could provide further insights on manifestation of both injury exposure and as well as injury risk. So that sort of informed the project that we're going to be talking a little bit about today. And I think one of the unique contexts of firefighting is that firefighters do work in these small teams for long durations. So different from police or from paramedics who tend to work in groups of 2 or in smaller, sort of more isolated groups, firefighters work in a slightly larger group. They come back to their station at the end of a call or at the end of a shift, and they have these small teams that they sort of build these peer support networks in. And it provides a unique context to sort of understand how firefighters manage not only sort of general work health, but also how do they manage exposure once they've had a high critical incident exposure. How do they work together as a team to manage that? So I think firefighting provides a really nice and unique context to sort of understand and identify different risk factors that are associated with post-traumatic stress injury. And then to narrow that down a little bit further, I've been really fortunate to build a research partnership with Thunder Bay Fire Rescue. And Thunder Bay, if you know anything about Thunder Bay, is an isolated, large urban center, I guess, in Northwestern Ontario, but we are quite isolated up here. And it is the largest professional fire service in Northwestern Ontario. But it's sort of in line with some of the isolation and some of the unique cultural contexts that we sort of deal with up here. The service itself has some local challenges. So Regan, I didn't know if you wanted to just speak to some of the local challenges that firefighters in Thunder Bay experience and are exposed to.
Sure, right. You mentioned, Kathryn, that being a relatively isolated community, some of the challenges we face, as you can imagine, are, timely access to training and access to training in general. Public perception can be a challenge as in any community, but I think sometimes here the spotlight is a little more highlighted. Also, we cover quite a significant geographical area, and we need to flex between both urban and rural rescue responses. And also in terms of accessing care for our personnel and community in general, there really is challenges to accessing healthcare, both from a preventative and a treatment point of view.
Yeah, that's great. Thank you. And maybe you want to speak a little bit to the partnership that we've been able to establish over the last few years?
Next slide.
Is it up?
Sure, absolutely. So this slide here, basically in recognition of past work we've done and the problems that we've outlined, a strong partnership has developed. We've been working together closer to 5 years now, and the stakeholders include the Thunder Bay Professional Firefighters Association, the City of Thunder Bay, represented essentially by Thunder Bay Fire Rescue, and Lakehead University School of Kinesiology. And you see myself there in the middle listed as the primary knowledge user. So my job really is to act as a liaison between the 3 primary stakeholders in helping to drive this research that Dr. Sinden and her team is doing, and also to really look at integrating the knowledge into practice here in Thunder Bay Fire Rescue.
Yeah, so I just want to build on that point a little bit. So we do use principles of integrated knowledge translation to facilitate our research approach, which means that Regan and his team work really closely with me to ensure that the research that we're delivering is contextually relevant, and they sort of help to identify research priorities, which is kind of where this work evolved. And I'm going to let Regan talk a little bit about their mental health program, sort of that they were using prior to starting our research project together.
Right, and we had our mental health program that led to this research essentially, and you see here it kind of looks like the fire detector heater, doesn't it? Back when we started this, we had the critical incident response team that would respond to critical incidents here within our department, and you can see that team was central to our mental health program. And within that, we looked at a diffusing approach. We helped with informal peer support to our membership. We also act as liaisons, kind of a resource for people to try and access family assistance programs available here. and also to access any personal benefits that we carried with our duties here at Thunder Bay Fire Rescue.
Yeah, that's great. So as we were building this work, Regan and I were sort of reflecting on these different components of their mental health program. And we were sort of reflecting on whether or not that program and those elements were working the way that they were intending them to work. So really the overarching purpose of this work was to identify the preferred components that could be retained in their critical incident stress management program and really try to drive towards a more evidence-based approach. So to address that overarching purpose, we had 4 corresponding research objectives that we tried to address. The first was simply to identify the burden of critical incident exposure and then how that was manifesting as an indicator of post-traumatic stress injury risk amongst the service itself. So that was just first and foremost, we wanted to understand what was the problem, what were we looking at, and just sort of understand the burden that was being experienced. Obviously, we could have looked at multiple mental health disorders, but for the purposes of this project, we were just really focused on PTSI risk at this point. Our second research objective then was to identify the impact of delivering components of the program, particularly from the perspective of the CERT. So this was something novel that we thought we would bring to the research program and as well just to the literature itself. I mean, there's a lot of evidence out there, and we just heard a talk that was talking about the importance of peer support. And critical incident response teams are basically a form of peer support. And I think one of the things that Regan and I were starting to talk a little bit about was how effective is this as a team? And then not only that, but what is the burden of acting as a CERT member on their own mental health and on their own health and well-being? So that was something that we decided we wanted to explore in this project. And then third was just to identify firefighters' experience, so the service itself, what was their experience with the critical incident stress management program following exposure. And then of course, really important, I think when we're doing this type of, integrated collaborative work with a research partner is to have a deliverable. So, the final sort of objective was to provide a report and outline some steps in terms of identifying new resources and or potential modifications to their program based on the findings that we sort of identified. So today I'm really going to focus on objectives 1 and 2, and we'll bring us a little bit to objective 4 as well. So to address objective 1, I'm going to just kind of go through some of our methods, just so you can understand sort of how we approach this. So our sample was TBFR firefighters, anyone that was active duty at the time. Thunder Bay has a complement of just under 200 firefighters in suppression right now. So that was our sample. We collected data about a year ago, so between December and January. Thunder Bay Fire Rescue is comprised of 8 stations and 4 shifts, and Regan and I worked really hard to ensure that we had representation across all 8 stations and 4 shifts. In terms of data that we collected, we were interested in looking at various demographic variables that I'm going to be reporting on shortly. But then as well, we had a question on that demographic questionnaire just to get an idea of what firefighters in Thunder Bay were sort of looking to and what they were accessing in terms of care and strategies for managing their mental health. So we had a question that sort of helped us identify that. What were they using in terms of mental health management strategies, including informal and formal sort of components of that. To understand exposure, we administered the critical incident inventory, so you're probably aware of that particular tool. It has 24 items, 6 subscales, and uses a 2-month point prevalence when administering that. Just give me this. And as well, we had to identify how that was manifesting, how that exposure was manifesting in injury and or illness. We administered the PCL-5, which is a measure, most people are aware, of post-traumatic stress injury risk. It's a 20-item self-report measure of PTSI symptoms and exposure with a 1 month point prevalence for the DSM-5. So just some results from that work. We were able to sample 143 participants. Again, these were all firefighters and or others that were in suppression. One of our sample was female. The average age of our sample was 40 years. Firefighters in our sample had just over 11 years of service. 76% identified as firefighters, and 11 of our sample were CERT members. So moving on to some quantitative results from our work. So we found when we analyzed the critical incident inventory that 91% of Thunder Bay Fire Rescue firefighters experienced at least one critical incident in the 2-month point prevalence time period that we were assessing. And that corresponds to some of our pilot data that we had previously collected as well. And then we decided, I'm just going to bring you over to this particular column over here. You can see that what we actually did was we decided to analyze some of our outcomes per each one of the 6 subscales on the critical incident inventory. So you can see along the horizontal axis, these are each one of the 6 subscales. So trauma to self, victims known to the firefighter, multiple casualties, incidents involving children, unusual tactical operations, and severe medical trauma. And then on the y-axis, you can see where we reported exposure to more than one critical event. So this is percent of firefighters that reported exposure to more than one event in each one of these 6 subscales. And what you can see from this data here is that the highest subscale that firefighters were reporting more than one exposure to in Thunder Bay was multiple casualties. So I can go through items if you're interested, what sort of is maintained within that particular subscale. It's probably pretty self-explanatory based on the name of the subscale. And then second to that was unusual tactical operations. So 69% of Thunder Bay Fire Rescue firefighters reported more than one event that would be classified as an unusual tactical operation. And then 66% fell under the trauma to self subscale. So that's sort of the critical incident inventory results. I'm going to bring you down to this bottom little text box down here. And this aligns with some of the demographic data that we were collecting. And kind of brings us to our third objective, where we were just trying to identify what kind of resources Thunder Bay Fire Rescue firefighters were using following exposure. And what we found was that almost 11%, which I don't think is a lot, but 11% used formal critical incident stress management resources, including the CIRT, and the majority of the service preferred informal crew discussions following the incident. And that aligns with some of the literature that we've been reviewing over the last couple of months as well. So that's sort of the results that sort of provide some insight into exposure that firefighters are experiencing in Thunder Bay. This next slide provides some data in terms of how it's manifesting in injury and or illness risk. So you can see on the left this pie chart here. This is again results from the PCL5. I guess down below you can see that 86% of firefighters experience symptoms of PTSI. So that kind of gives you an idea of the burden that they're sort of undergoing within this service. And this is probably slightly underreported as well. And we can speak to that if you want in the discussion period. But this pie chart gives you an idea of how we sort of stratified these results from the PCL5. So we stratified our results into low, moderate, and high. And I think what was kind of interesting and or concerning to us was that 20% of the Thunder Bay Fire Rescue firefighters reported experiencing moderate to high risk for PTSI. And then 66% fall into this lower category over here. And then we were really interested as well, the research assistant and I that were working together on this project thought, you know, it might be really interesting to parse out whether or not there's a relationship between the way injury or illness risk is being manifested and exposure. So you can see on the x-axis here, we have total CII score, and on the y-axis, we have the total PCL5 score. And what you can see is that there's a low to moderate relationship between total CII score, i.e. exposure, and the way it's manifesting in injury and or illness, although it is significant. So you can see this clustering down in here where there's a low CII score and low PCL5 score, but you can see some of these higher PCL5 scores up here where it's suggesting that risk might be higher, but still the total CII score probably isn't quite as high. And what this might be suggesting is that these higher levels aren't necessarily related to immediate risk, but maybe speak to the cumulative trauma that's so unique within this occupational group. So the second objective that we're going to present on today was the impacts. And I think this was a really kind of interesting component of the work that we've been conducting over the last little while. So what are the impacts of delivering components of this particular program, particularly from the perspective of the CIRT team? And again, so our active duty firefighters were our sample, but you obviously had to indicate that you were a member of the CIRT. We collected data early on this year. We were also interested in re-administering the critical incident inventory just to see whether or not these particular exposures were different for this particular group. And then their PCL5. So we were kind of hypothesizing potentially that PCL5 scores might be higher within this particular group. And we haven't analyzed that data yet, but we will be soon, I'm sure. The results that we're going to be presenting today are from the qualitative semi-structured interview portion of this particular component of the project. And this is a sample of some of the questions that we asked. So how does the current CISM program impact your overall health and well-being, both from work and family perspectives? How does being a CERT member affect your general health and well-being? And then how does being a CERT member impact your personal response to challenging calls? So that just gives you an idea of some of the questions that we were sort of exploring with this particular sample. And these are some of the very preliminary results. So we've done some preliminary analysis of this work. We've identified four primary themes. Theme one being on-duty response impacts natural truck-to-table talk process within the crew. So this was something that we saw commonly within the CERT members, is that they felt that being called out just sort of disturbs this process, and which is so inherent within fire as it stands, that they have these really intimate small groups that they can sort of hash things out after a difficult call. So it sort of interrupts that natural flow of managing some of these higher exposure incidents. Theme number two is off-duty calls place high burden on CERT and their families. So often members of the CERT are off-duty when they're being called to support their peers, and that obviously probably makes sense that it places a high burden on the member themselves and of course on their families as well. So needing to recognize and understand that. Theme three, again, off-duty CERT members feel unprepared to respond to individual firefighter distress calls, so there's a need for increased supports. And then CERT members indicated a need for more resources to address mental health in the service, so addressing that as a potential need within their health management program. And when we reflected on these four themes and sort of brought them together, we kind of hypothesized that perhaps this CERT may not be the most effective model to manage firefighter mental health, and or probably requires more support around it. So it kind of brings us to some of our take-home messages. I think first and foremost, I'm really fortunate to be able to work with firefighter Bolduc. He's very active in the research processes and provides really unique insights into firefighter work health that I couldn't get without sort of having that close sort of lens into the firefighting community. So having an effective firefighter or primary knowledge user facilitates the development and implementation of evidence-based strategies in the fire service. One of the things that firefighter Bolduc and I kind of reflected on was that, as we sort of move a lot of this work forward, it certainly opened dialogue regarding mental health within the service. And obviously, when we start talking about mental health and some of the challenges that we're experiencing, it starts to reduce the stigma that's so inherent within this particular occupational group. Thirdly, developing evidence to support mental health initiatives within the service, I think, is really important. So how can we use some of these research results to sort of develop and support some of the initiatives that they want to move forward? And then this particular point I think is important. We've been talking about this a lot over the last couple of years, and we've just done a knowledge synthesis on this particular approach as well. That's the whole idea of peer support, and certainly it comes up time and time again, and certainly there's probably a role for peer support, but that as a standalone method probably isn't the preferred approach, and particularly in consideration of the CERT team. And I'm going to turn it over to Regan just to sort of build on that and then talk about how some of this work's affected TBFR's mental health policy and procedures.
Sure, and in the interest of time, I'll keep this short and sweet, but basically, Kathryn, you already mentioned it. We really need to consider the burden on critical incident response team here and really need to use this data we've gotten to help drive our new mental health policies and procedures. So we'll review that in the next two slides really quick. If you'll remember, there's our old program, which is what we researched and studied with the critical incident response team in the middle. And what we're proposing is to, the next slide, look more at evidence-based solutions, right? Driving our mental health initiatives going forward. I'd like to see that steered by a psychological health and safety committee across the department with good representation and still provide informal peer supports and resource for our EAP and benefits programs.
Great, thanks. And just really quickly, in terms of a status update, we're going to be repeating some of the measures that we conducted corresponding to objective number 1 and running some qualitative interviews to explore TBFR preferences to support their mental health. So in follow-up to objective number 3, facilitating some knowledge translation strategies as well. So we tend to run research days where we can bring some of the results back to the firefighters. So finding a way to do that in this new climate. And then some lessons learned, just the importance of a strong research partnership, and then adapting some of our data collection methods. So with that being said, I just want to acknowledge and thank the Thunder Bay Fire Rescue firefighters who always continue to show up and volunteer to participate in our work. Chief Hankio, who is always a big supporter of this, as well as the president of the Thunder Bay Professional Firefighters Association, Dennis Breskison, and then members of my research team, Serise and Dr. Kathy Henderson, Dr. Kathy Sanderson. Thank you.
All right, thank you both so much. I just want to say that I love that you're using integrated KT. I think that's great. All right, so I will want to introduce our third group for the day. The project is titled Psychological First Aid for Emergency Medical Technicians to Prevent Post-Traumatic Stress Injuries After Exposure to a Traumatic Event. Can it work? It is going to be presented by Dr. Steve Geoffrion, Associate Professor at the Université de Montréal. I apologize for massacring that. His knowledge user for today is Teresa Choisy. So I will turn over the sharing of the screen to you.
Okay, good afternoon, everyone. Just while I'm setting up my PowerPoint, it's my turn now to apologize for my broken English. It's been a while with the pandemic since I gave a talk in English, so it feels like I have a lot of potatoes in my mouth at the moment, but I'll try to do my best. You will have my contact information if you don't understand what I'm saying, so just write me an email after my presentation. So let me introduce you to our CIHR Catalyst project. First, I want to introduce you with our teams. Sorry. So I was the lead investigator in this project, but today I'm really presenting all the work of my PhD student, Miss Marine Tessier, who is using this project for our PhD thesis in clinical psychology. And today with me is Miss Teresa Choisy, who is the representative of the knowledge user of this project. So for this project, what was the problem that we address? Like Dr. Price, Price said earlier, we have a lack of efficient evidence-based early interventions to prevent PTSI. Even though that we know that early interventions can prevent the emergence of psychological problems after the exposure to a potentially traumatic event. We know that the most widely early intervention offered now is psychological debriefing, even though most of the international guidelines do not recommend its delivery anymore. We know that PSP prefer internal support rather than external support, and now we have an international recommendations. All the experts are fostering the provision of psychological first aid. I think with the pandemic, you have read about it, you have heard about it. So the project here was to assess PFA in a EMT organization. But what is psychological first aid, and why does expert think it's a promising solution? Well, we have to know that it's a trauma-informed early intervention approach. It is supposed to be flexible and adaptable to all settings. It can be delivered by emergency workers such as PSP. It aims to reduce psychological distress in the hours after the exposure to a traumatic event. It fosters the use of evidence-based coping strategies in the days, weeks, and months after the exposure, and it promotes access to care services. But like my colleague says earlier, there's really a lack of evidence, a lack of empirical evidence that this kind of approach can be implemented in high-risk organizations. And what about its efficacy? We don't know about the efficacy of psychological first aid to prevent PTSI. So just to give you more information of what is psychological first aid, it consists of 8 core actions that are based on CBT strategies, cognitive behavioral therapy strategies that are known to be efficient in trauma treatment. So we have 8 core actions that take 1 day to 2 days to train. So we can train people in 1 to 2 days to these 8 core actions, and these 8 core actions are aimed, to increase adaptation functioning after the exposure to a traumatic event by restoring a sense of safety, a sense of calmness, a sense of connectedness to other people, a sense of self and community efficacy, and also it will provide hope that you can cope with the situation and then you can grow from this situation. So now I will just pass the mic to my colleague, Ms. Teresa Choisy, that will tell you about how Urgence Santé, which is the biggest EMT organizations in the province of Quebec, and it's located in the Montreal area, how do they implemented PFA among their services?
Thank you, Steve. So I'm going to give you full information about Urgence Santé. Like Steve said before, we are one of the largest pre-hospital emergency services in Canada, and we handle close to 375,000 emergencies each year. We have over 900 paramedics and over 100 emergency medical dispatchers, EMD. The PFA program started approximately 4 years ago, and it is really dear to the employee and the organization. So now let's dive in. So how can one become a PFA peer helper within our organization? To become a peer helper, a paramedic or EMD can be nominated by their peers or apply to the program. Successful applicants will be interviewed to verify, among other things, the absence of a PTSD event in the past year, which is one of the exclusion criteria. Then they will be trained under the supervision of a psychologist based on the PFA protocol. The PFA peer helpers will also receive a complementary training with a suicide prevention line. In the past 2 years, our 32 PFA peer helpers have performed over 140 interventions. The PFA program has a logistic in place to identify peer helpers among the employee, allow their intervention in an operational context, and ensure post-intervention follow-up. So Steve is now going to continue with the study.
Thank you, Teresa. So our study was to, start to dig up some empirical evidence about PFA in high-risk organizations. So it was, as it was a pilot, it was a feasibility study with 3 main objectives: to assess the acceptability of PFA, to assess its implementation, and to assess its limited efficacy. So one of the first studies that is now under revision for publication addressed the question, to what extent is PFA acceptable and usable by EMT peer helpers? So PFA was delivered in a peer support format there. So we conducted semi-structured interview with 11 PFA peer helpers, and we did thematic analysis using NVivo to analyze those data. So first, related to acceptability, the participants, the peer helpers, said that, well, PFA has a good fit with the fast delivery culture of EMTs. This adaptability and ease of use increases their feeling of competencies in giving psychological support to their colleagues. Moreover, the individual and the group aspect of the intervention of PFA all increases the perceived appropriateness of PFA for these kind of workers. They also observe positive effects on the organization of providing PFA. They said that PFA updated the psychological support provided to EMTs in their organizations, and also on more an individual basis, it improves their capacities to psychologically support distress among citizens for whom they are giving services. On the other end, though, they perceive some individual negative effects that kind of replicate the results of the prior study we saw together. PFA peer helpers says that it increased their workload and also it increased their mental load. Pertaining the implementation of PFA, peer helpers observed that gradual implementation of the approach and overall management support and material support given to them to provide PFA facilitate the implementation of PFA in the organization. However, they perceive some possible threats to its sustainability. The fact that there is still no scientific assessment of its efficacy in preventing PTSI asked them the question, will we have enough money, to kind of make this project going on? They also said that PFA peer helpers have no symbolic acknowledgement for the moment, neither they have financial compensation or reduction of field hours. So it's really impacting their work. It's putting more burden on their shoulders. Also, the fact that there's a lack of continuous training and clinical supervision can also threaten the sustainability of PFA in this EMT's organization. On the aspect of execution of delivery of PFA, they say that when managers help to access the service, it facilitate PFA delivery, and also the fact that they can have some punctual advices and support from psychologists and colleagues to give better PFA interventions could help them. On the other hand, they say that when managers interfere in the process of PFA delivery, or when the protocol for accessing PFA is really complex, will hinder the PFA delivery. So that was the main results of our first study. The second study we did is still in the phase of preliminary results, relate to the question, to what extent does PFA respond to the needs and expectations of EMTs coping with PTSI? To do this, once again, we conducted semi-structured interview with 13 EMTs that were coping with PTSI and that received PFA interventions between August 2019 and March 2020. So thematic analysis gave us 3 big themes, one pertaining to acceptability. While PFA recipients saw that in their organization receiving PFA and their colleagues receiving PFA, this stigmatized mental health problems in this organization. It also promotes demand for psychological aid resources and also promote the access to such resources. And finally, they saw that it enabled faster and more efficient return to work. About the implementation, they reported several aspects that will increase their experience. Well, they will have a better experience of receiving PFA. They said that the characteristic of the provider of PFA, and here the peer helper, is really important. They have to feel confident in who is the provider and in the skills to provide PFA. For some of the participants, they say the closer they were to the PFA helper, it was better, but for other ones said, well, we prefer that we have some PFA helper that do not work directly with us, who just know us a little. And all were unanimous that the interpersonal qualities of the provider were very, very important, suggesting that the next time when we're selecting who's going to be PFA helper, we should assess really thoroughly these interpersonal qualities. They also said that the characteristic of the PFA intervention could really affect their experiences. They say first that access to PFA services must be easy, must be confidential, and at some point, if they don't want to have PFA again, refusal must be respected. They also said that the PFA is really good for them because the assistance provided is practical, so it has to be concrete. And the timing of PFA for them says that earlier we received the PFA intervention is better, but a punctual intervention, just one intervention is not enough. We need the follow-up. The follow-up, so the PFA peer helper calling him each week is really, really important in their experience. Finally, they provide us with some information on the potentially the limited efficacy of PFA. After receiving these interventions, they felt calm. They felt that the process humanized their conditions. It normalized their PTSI reactions. They feel more equipped to manage their reactions. They feel heard and respected. They felt understood, and they also felt supported in adversity. So that is the main result, preliminary results of our second study. Finally, I'm just going to show you our third study. Well, our third study is aimed to answer to the question, does PFA improve recovery and work functioning more than usual support following exposure to a traumatic event? So if you look at the figure here, it's a randomized controlled trial that we want to do in the next year. At the moment, we have 320 participants that have completed the baseline assessment, and now we're waiting that they experience potentially traumatic event to be randomized, whether to the PFA peer helper groups or to the usual support that is provided in the organization, which is basically a referral to the employee aid program. But if you're familiar with studies in trauma setting, it's really a big challenge to conduct RCT in acute stress time frame. Victims are hard to reach in a short period after the exposure. PFA helpers, who are the best one to recruit those participants, are most of the time uncomfortable promoting such a research project to people who are in distress that will have to file some questionnaire. And randomization seems sometimes unethical. If we give some PFA to one, why don't we give it to another one? So it's a big challenge to conduct such robust design in a naturalistic setting. We also have some challenge in the past year to conduct this third study. The pandemic did not help us. Randomization protocol was hard to apply in this situation. And the fact that Urgence Santé implement throughout all the organization PFA gave the perceptions to our participants that it is really it is already efficient, so why do we have to do a study about its efficacy? So take-home message, if we want to build up on these evidence on PFA, we still don't know if it's really efficient to prevent PTSI, but still, if you want to implement it in your organization, we think that you should train a broad range of workers regardless of the training and psychological support, since PFA will increase their competencies in providing such support. We have to enforce a strong managerial commitment and support. We have to facilitate access to PFA services. We have to acknowledge the work of PFA helpers, and we have to support the confidentiality of this approach. On the other end, if you want to provide such PFA services, don't forget to plan continuous training and clinical supervisions. Do not let managers interfere in the PFA intervention process. Make it easy to access PFA. So don't make a multi-step procedure to access PFA. Add PFA peer helping as a volunteer work is not recommended because it increases the burdensome of these workers. And don't forget to put a lot of emphasis on the follow-up sequence of the PFA interventions. So thank you. So this is my email address. If you have some question, feel free to ask them. Thank you.
Thank you.
All right, thank you both so much for your presentation today. Very interesting program. So we do have a little bit of time for questions. So if you have a question and you want to go ahead and submit it through the box, you can. I do have one quick question for project number 1 team. If you wanted to pop back on, I can ask that. All right, so the question is, since there are so many services out there that you're constantly finding more, will you have a stop date on the database that you produce? So will there be kind of a date where you go, we only looked until this date for services?
There will be a date listed on the website as what date it's been updated until. We're hoping to find someone to take on the role to update it, but this is still something that we're still considering. We're waiting until the website's actually finished before we can make a final decision about whether or not or how long the update of that website continues.
Okay. For team number 2, this is a question that was directed towards Regan. They wanted to know what you feel the benefits of having an integrated approach have been for your organization when looking at sharing the research knowledge.
Yeah, I guess it helps with communication for sure, making sure everyone's on the same page and really trying to integrate what we've learned from our past research and what's out there, and really trying to apply it to our policies and procedures. So really key with that communication piece.
Perfect. And one question for project number 3 about your program. And I listening to your difficulties, I can understand. Have you considered choosing a, I guess I want to say, I'm trying to word this best way, a mirror service to test with versus because you said it had been implemented in the entire one service already, that picking a matching service to test against?
Yeah, well, we wanted first to try a randomized control trial because we wanted, the best research design. But I guess that in the next year, if we don't have more participants that are randomized, we'll have to think about it, and we have them to ask them if they want, to be the control situation. So it's also really hard, to approach an organization and say, oh, we have a good project in one, but you want to be the control situation. So that's another option we have. Thank you.
Perfect. All right, so it looks like those are the questions that we have for today. So I'm just going to do our little wrap up here with everybody. And I want to thank everybody, of course, for coming and presenting today. This is wonderful research that you're doing that I think is going to do a lot of good for the public safety population. So I want to thank you all for that, for being here today, and especially the knowledge users, again, for sharing your view on this research. I think that's super important. As we reach the end of our session, I want to ask you to complete the survey that will appear after the session is completed. You'll receive a follow-up email tomorrow with a video of today's session, and we will have those knowledge reports posted as well. CIPSRT will be co-hosting a webinar on community-based research. The session is designed to give not-for-profit or public sector groups information on how to have more impactful collaborations with university researchers, and that will be held on February the 10th. We'll also be continuing the post-traumatic stress injury series on February the 11th. If you haven't signed up already, the link is available on our website, and it will also be in the follow-up email. Thank you again for being here today. Just a reminder, it is Bell Let's Talk Day, and now more than ever, we need to make every action count to support mental health. So again, thank you to our researchers and knowledge users for being here today. To everyone out there, take care and stay safe.